Where is the microphone?
Dear friends and colleagues around the world, good morning, good afternoon, good evening to all. Welcome, and thank you very much for joining us today for this special program to mark the International Day to End Obstetric Fistula, which, as you know, is in a couple days on May 23rd. On behalf of UNFPA's Technical Division, Sexual and Reproductive Health Branch, Maternal Health Team, and the Campaign to End Fistula, we are delighted to welcome you to this special seminar and interactive dialogue with fistula surgeon, Dr. Steve Arrowsmith. So to introduce Steve, Steve is a urologist by training, and he's in his 33rd year of fistula work. He founded the Evangel Fistula Center in Jos, Nigeria, and served on the surgical staff at the Addis Ababa Fistula Hospital in Ethiopia. He has served as medical director of the Fistula Foundation, consultant to Fistula Care and Fistula Care Plus within Gender Health, head of the Fistula Program of Mercy Ships, consultant to Direct Relief, and vice president of the Worldwide Fistula Fund. In addition to Nigeria, Steve has helped open new centers in Sierra Leone, Ghana, and Niger. He has performed fistula repairs in 17 African and Asian countries and has a passion for the mentorship of new fistula surgeons. Steve was co-investigator on Fistula Care's groundbreaking clinical trial on catheter management after fistula repair. He has authored multiple academic articles and textbook chapters on fistula and served as technical advisor to the film A Walk to Beautiful, which many of you may have seen, a very moving and beautiful film that I love. Steve's work has been featured in the New York Times. He has given testimony on fistula to the US Congress, lectured major societies, including the American College of Surgeons, and met presidents and princesses along the way. But Steve prefers to hang out with fistula ladies, from whom he has drawn many life lessons and much personal strength. Steve, a very warm welcome, and many thanks for being here with us at UNFPA headquarters today. So Steve is going to walk us through some of the highlights of how fistula, the world of fistula, has changed in the past 25 years since the International Conference on Population and Development in 1994. And then we'll have plenty of times for question and answers from all of those colleagues online and in the room, which will be facilitated by Bridget. So Steve, once again, warm welcome, and take it away. Thank you.
Thank you, Dr. Aaron. I have official permission from Aaron to finish early, if that suits everyone. So we'll see how this goes, but definitely we want to reserve plenty of time at the end for questions, because we want all of you out there in the real world to be able to participate as well. Let me start off. I know many of the field staff in UNFPA and Fistula out there from traveling over the years, and I'm still in a phase of wanting to acknowledge and be thankful for all of you guys. In November of 2017, I found myself in an awkward position as a surgeon, and that was having very, very major surgery myself as treatment for newly discovered cancer. And afterwards, I had some horrible complications, and my daughters put out the word on the internet, and I had this outpouring of support from people like you all over the world. And if any of you were part of that, I want to say thank you and acknowledge how meaningful that was and how much I appreciated it. I also got a video get well card from Nick Kristoff. But anyway, so for any of you who were a part of that, thank you very much. And you don't know what that meant. And I'm just very grateful to be back out on the road and healthy and still a part of this great work that we all do.
Glad you're back in action.
And as we begin, we want to acknowledge the women that we serve out there too, that we are the ones who represent them to the international community, to those with the resources to deal with this issue. And we want to keep them at the center of everything that we think about and talk about. this morning. So as Aaron said, the specific occasion for this morning is the upcoming International Day, but the excuse that we're using for this presentation is something that's going to happen around the time of the International Day, and that's the release of the second edition of the manual on obstetric fistula that was published initially in 2006. And just for sake of brevity, we're going to refer to that as the Orange Manual, as everybody else does, because the cover originally was orange. So that we're celebrating Orange Manual version number 2. And so the outline that Aaron suggested, and I think makes a lot of sense, is to just talk about maybe some of the top things that have changed between version number 1 and now, and to get a perspective on how much has happened in the world of fistula, which is just really incredible and humbling to see what's happened, and also to remain challenged by what there is left to do and not to sit back and rest quite yet. So with that framework, we'll go on. I want to thank everybody at UNFPA. At this moment, I want to thank Veronique for getting the computers working so that we can do this. I've been very much supported by Dr. Aaron and by Bridget at the Campaign to End Fistula in the process of dragging this new version into reality. It's been obstructed labor at times, but I think that we're going to make it here soon. And also, finally, to the more senior staff in the technical division, including Benoit, Kalasa, Annika, and Gita, who have also lent their support to this effort as well. So thank you to all of them, and I won't try to mention everyone else on the UNFPA side. We tried to make this a very much collaborative process, and this is, you don't need to memorize this, but this is the list of our reviewers and collaborators, and this is really a wide range of people. There are Africans and Asians, there's Francophone people and Anglophone people and other phone people too, and there are men and women, there are public health people, there are surgeons, there are funding agency administrators, there's physiotherapists, there's social scientists, and a number of nurses as well. And so we tried to get a broad range of input to make sure that we were representing the full range. And so thank you to each of these people. And I wish Satya would get a shorter last name. Satya is the UNFPA person in Bangladesh. So, anyway, so thank you to all of these, our reviewers, and please realize when you hear about this, this is not only my opinion, but stuff that's been run through the filter of other people's feelings as well. So first of all, who am I? I think Aaron took care of that. But I just wanted to underline that fistula has really been the driving force and driving passion in my professional life. And so it's really a privilege in these years where I've begun to grow gray hair to be involved on a level that's more international with people like you out there, and not just in the operating room. I think that I've had a rare privilege to be on kind of all sides of this issues, not only clinical, but also in programming and fundraising and research and advocacy and the whole thing. And so I'm not expert in all of those areas, but I have done work in those areas and have some familiarity and feel your pain if you're in one of those places. So, to me, it's amazing that Volume 1 lasted 13 years. I mean, version 1 of the Orange Manual lasted 13 years. And I can remember many times a long time ago thinking, where can I look something up about fistula online, and really finding that there was only one book or one publication, and that was this thing we've come to call the Orange Manual. if you read it now, it does seem a bit dated, and that's not because of the quality of publication, but rather a reflection of the pace of change in the world of fistula. So hats off to Gwyneth Lewis and to Luc de Berny and the work that they drew together back for version #1. So just as an introduction, we need to just cover what this manual, first of all, is not. It covers everything, so it can't be authoritative and complete on anything. Okay, so it's an overview of programming, it's an overview of surgery, of nursing, of physiotherapy, of social interventions, and all of those things at the same time. And so we hope that there's something in it for people involved in the full range of fistula activities, but realize that it would have been 42,000 pages long if we tried to cover everything there was to cover on each of those topics. So what it is, I think of, is one more tool in what I think is one of the most important new trends in fistula, and that's just building a community of practice. We can mean that in clinical terms of networking surgeons together to talk about difficult cases, but I also believe that we're a community, all of us who are working on fistula together, and the manual is one place where we can begin and look and find information together, and also just to be introduced to the people who truly are experts in each one of these different aspects of fistula. So the intended audience of the manual is everybody in fistula. I don't think we have a lot in there for patients, I should say, but we'll have to ask their apologies and limit it to the people working in the field of fistula. So that's what it is and what it is not. We want to recognize how much has changed. So much has changed, we even had to change the title. You can't even say obstetric fistula anymore, and we'll talk about why in a few minutes. And so we call it, what, female genital fistula, because obstetric fistula now has company as being one of the major causes of fistula disease out there, if that's what we want to call it. So even what fistula is has changed. And because of that, who is suffering from fistula has changed. We used to have a very clear picture of what a classic fistula lady looked like, and that has changed a lot. We'll talk about that in a few minutes. We've gone from an area where there was very little work to a new world. I used to always tell everybody early in my career, I did my first fistula repair in 1987, and some of you maybe weren't born yet. But I used to say I'm one of the top 5 fistula surgeons in the world. Of course, there's only 4 of us, but I'm right there in the top 5. And nowadays, I'm sure you're all aware that you can no longer say that there's a large community of people working clinically, people working in public health, people working in development, people working in fundraising that all have come together around this issue. The priority issues, the priority challenges have changed. In 2006, we were still very much up against what we used to call the hidden epidemic, that first and foremost, we had to get fistula out in the open and into the public eye. And we made a lot of compromises, I think, early on, just to be able to begin to offer care somehow out there. And I think we've moved on to a different era about what the pressing issues are. And so we'll talk a lot about that. And then finally, in view of the changes, all of you who are involved in fistula programming out there need to consider how these changes affect your future planning. I do not believe that the way that we used to do fistula in 2006 makes as much sense as it did then, as it will now, or as it will in 2022. So I'm hoping and praying that all of you are malleable and willing to make course corrections now that we have a couple of decades of experience under our belts, and to move forward from there. Even though things have changed, there are some things that never change in fistula. And number one is we're going to talk a little bit about the fact that there may be fewer women with fistula out there than there were in 2006. That should be a good thing. But the paradox of development is that we all need our own cause to go on forever. But anyway, even if the numbers of women may be reducing, even a single woman with fistula, I believe, is motivation enough to keep going, keep working, to find her and get her help. And so we don't want to throttle back because we're seeing maybe the numbers of incidents reducing a bit. One thing that never changes is that we all need more money to do what we do. And we live in a completely different money environment these days than we did in 2006, I would say. And that has to be taken into account. But we need more. We need better information. That never changes. We've had bad epidemiologic information from the beginning. We've had a bad evidence base of the care that we do. And gradually, those things are beginning to change, but we need more information, and that's an ongoing need. As I just brushed upon a little bit in this idea of the community that we represent, we need to work together in unity and collaboration. Karen Beatty, who used to run the Fistula Care Plus program at Engender Health, introduced me to the term of collaboration, which was kind of representative towards how a lot of the different organizations viewed each other. We were in the same sphere, but a little bit suspicious and a little bit jealous. And I think that probably will never change, but there's been a lot of progress there too. One thing that does not change, and we always need to keep in mind, is if you are the country office in Mali, your situation is going to be different than the country office in Kathmandu. Fistula is different everywhere that we find it. There's a different range of injuries. There's different challenges with interfacing with government. There's different range of resources. So there are no world solutions to fistula. And we need to feel free to come up with local solutions, and that's never going to change. One thing that's never going to change is that fistula is unique. I've heard that it's public health in a surgical sandwich because public health, fistula is a public health grade issue, but both the prevention and the treatment of it is surgical, and that means hospitals and surgeons who are hard to get along with and all of that kind of stuff. And this was something that was brand new in the early years of fistula, and continues to need our attention as we move forward, that we can have grace for each other for having different ways of looking at things and approaching things. It's also never going to change that we're always going to have to balance how we use our resources between actually doing operations on women and all of the other things that women need, like they need to be found and identified, and they need to be facilitated in their efforts to get treatment. They need social help when they return home, and they need all of the effort about prevention, because everybody always says, well, it's cheaper to prevent a fistula than to deal with. That's true, but we have all these ladies out there with fistula. What do we do with them? So to keep all of these things as dual moral imperatives, that we have to treat them and we have to also prevent them, we have to help them in other ways too, and how we balance all that out is a challenge that's never going to go away. So this is just a list of top issues that we'll blow through, and you need to let me know if I'm going on too long here. But these are in no particular order here, but the issue of epidemiology has made progress. Let me just, we'll go through each one of these individually, so I won't go through the list here, but let's start with epidemiology. The history of epidemiology has always been a complete wreck in fistula. For a while, I was in on sessions where people would decide what the next worldwide prevalence figure was going to be, over dinner in a hotel somewhere. all of the numbers that you've quoted and heard, it's proven by an epidemiologist from Johns Hopkins named Cindy Stanton. She got so upset about hearing all of these wild figures. She went back and researched the index data for every single printed estimate of fistula prevalence and incidence ever, and found that 100% at bottom were based on conjecture or a guess that somebody made. And that's been the history. And every talk about fistula, every paper begins with, there are more than 2 to 4 million, 1 to 2 million, 1 million, 5 million fistulas in the world today. It's always been a frustration that that we haven't had exact figures, because we need those figures to know how to plan. If you plan differently for 5 million women than you do for 500,000 women, and so we need this information. One of the things that's changing, though it's not yet chiseled into stone, is that the numbers, the estimated numbers, is drifting downward. We've had the 2 to 4 million for quite some time. What's the current UN one? Is it 1 to 2 or 2 to 4?
Well, we have some new figures coming out.
But what's the current one?
So we are saying hundreds of thousands. It's approximately 500,000, but it's not published yet.
No, I mean the one that you've always used for the last few years.
For the last years, we've been using 2 million.
2 million,
2 million,
okay.
Yeah.
That's drifting down. First there was the London School of Public Health paper, and I know there are shortcomings of that, but I mean it was an honest attempt at using real science, and that came out with 1 million when everybody had always been saying 2 to 4 million, and oh my God, we can't say 1 million, blah, blah, blah. As Aaron was just referring to, there's new data just about to come out, and so our timing is unfortunate, because we would have loved for that to come out 2 weeks before the Orange Manual so that we can include the new estimates, but it's not quite there. And so if Aaron wants to say anything about that, she's allowed to, but I'm not, so I have to leave that one there. But the other thing, clinically, if you look at the annual repair numbers on the global fistula map, if you visit fistula sites, you can see that there's empty beds here and there now. Where I can remember a time in Addis Ababa when I was there, we had a 40-bed ward, and we had a 6-week waiting list, and we had 4 women in each hospital bed. We had 2 heads this way and 2 heads that way, and a standard 1 person, because the need was so overwhelming. It's just not like that anymore. So we need to not be afraid of this. We need to celebrate this, that we've made progress. But this needs to be reflected in our planning, and the manual addresses some of these things. But when it comes to epidemiology, I would say definitely in the very near-term future that better days are coming, that we really will have scientifically based epidemiologic figures that are based on the best statistical modeling techniques that are out there, and that hopefully we don't have to cringe when we say there are 1 to 2 billion or whatever. So better days are coming. So this is a big topic in the manual. One of the things about the reducing numbers is that client identification and outreach, that means different things to different people, but just finding women and getting them in for care is a different story now. In 2006, if you opened the door of a new fistula center, you could count on ladies showing up. In the US, we call that the chuck wagon approach, where you ring the dinner bell and say, come and get it. This is all you had to do, and the ladies would show up. These days, that's not true. And if you look at the places that are really busy, it's not the big traditional powerhouse academic places that are busiest. It's the places that have really good outreach programs. And so we have some new tools for outreach, some new strategies that are currently out there in the literature and being used in the new edition of the manual, and we hope that you can benefit from that new experience. And there are a lot of new strategies that weren't dreamed of. I mean, we were beginning to get into mobile phones in 2006, but the idea of being able to transfer money to get women to be able to come in, that was never there. Television ads, they ran TV ads in Kenya because Weston Kisa, one of the senior fistula surgeons there, one of his schoolmates owns like 8 TV stations. They had 1,500 women show up after an appeal, and 150 of them even had fistula, and the rest did not. So there are cautionary tales too. And then there's all sorts of creative approaches. And this picture, Yusuf, is from a little NGO in Southwest Kenya. And it was originally funded by UNFPA as an outreach thing. And he and his wife, Habiba Mohammed, run a really successful outreach program here. And they came up with a women's football team called Let's Kick Fistula Out of Kenya. And they were a really good team. So they would go out and kick butt for the first half and score 8 goals. And then during halftime, they would do awareness speaking about fistula. And so, like I said, it's different everywhere. Creative local approaches are the thing. But Yusuf was at one of the team's practices and had a myocardial infarction and died on the spot just a few months ago. So we've dedicated this version of the manual to his memory. So, okay. One of the biggest changes in fistula is this thing, we're going to refer to this as IF, iatrogenic fistula. Iatrogenic is a word that doctors hate because it means a condition caused by doctors, okay? This is not how it's supposed to be. Iatrogenic fistula is fistula that occurs not from a bad labor, but rather from bad pelvic surgery. The most common one being abdominal hysterectomy internationally. That may be different locally. Number 2 being cesarean section. And so this is one of the biggest new challenges. Everybody is talking about it. Everybody is seeing it, but so far there's not been time for data to filter into the pool of academic materials out there. So still our data are anecdotal, but I can tell you that some places are seeing growing, but still relatively small numbers, 20, 30%. Other places are seeing obstetric fistula being virtually replaced by iatrogenic fistula. I was in Bangladesh a few months ago, and new cases were 85 to 90% iatrogenic in some centers. Obstetric fistula is caused by untreated, prolonged labor, obstructed labor. Iatrogenic fistula is caused by bad pelvic surgery. So there's totally different causes, which means they demand a completely different paradigm for prevention. You know, the things that we've done to prevent obstetric fistula have been successful. They won't do anything at all for iatrogenic fistula, because this is about professional societies imposing accountability. This is about licensing doctors. This is about, you know, basically telling surgeons where to get off. So I don't envy anybody that has to try to prevent this, because I know how surgeons respond to this. But anyway, so this is a huge challenge. Another one is that the clientele is different. So all of us we know the classic picture of a fistula lady. She's a 14-and-a-half-year-old from a little village in northern Nigeria, who's one of 4 wives in a polygamous home, has no formal education, is desperately poor, didn't have any agency or anything when she went into obstructive, blah, 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 blah. Well, that's still out there. There are still obstetric fistulas. But in 2017, I went to the 25th anniversary celebration of the center in Jos at Evangel Hospital, celebrating 10,000 repairs at the place that I got to start back in '93. And there were a couple guys from the US for the celebration, and they needed a ride to the airport. And we were looking all around. A little while later, I saw them in the Mercedes being driven down the road by this woman. And I said, oh, is that somebody from the ministry? And, oh, no, she's one of the fistula clients. Well, she had an iatrogenic fistula, because anybody who goes for a hysterectomy or for fibroid surgery or anything like that now is subject to having a fistula. So the picture is really changing. We can't claim that these are only poor, illiterate, uneducated women. It now includes nearly everyone else too. So the demography is changing, and that has to change our approaches as we do awareness and fundraising too. This iatrogenic fistula, as I've said, changes everything about prevention, and this is covered in the manual too, that there's been huge progress in maternal mortality, maternal morbidity, beyond. I used to just scoff at people when I was, early on in my career. Oh, all you have to do is make, maternal deaths start going away. And but like, that's never going to happen. Well, it has happened, and that's amazing. So there's been huge progress there, thanks to the Millennium Development Goals, Sustainable Development Goals. Once again, Bangladesh has been the poster child. They're really slashing their maternal mortality rates, and they're seeing the same in maternal morbidity. But all of these efforts, we need to go not now from figuring out how to prevent OF, but how to sustain those efforts as time goes by. So we're into maintenance mode now instead of creativity mode, and that's a whole different challenge in programming. But the huge new challenge, as I said, is iatrogenic fistula and finding ways to get ministries of health to impose standards of care, maybe to follow up on individual cases to see what has gone wrong, and that's a big challenge. There's been a lot that has changed in the status of fistula surgery, and one of my favorite ones is that when I started out, I said I was one of the top 5 fistula surgeons out of 4, but at least 3 were white guys from Amsterdam or the US or from London. And now, in a relatively brief period of time, I'm proud to say that African and Asian surgeons have just taken over. They are the seriously qualified, seriously experienced surgeons now. The president of the International Society of Fistula Surgeons, we're on our 2nd national rather than international president there. And sorry?
Female.
And she's a woman, yeah, too. But so this is just very encouraging to see, and I think is a model to other works out there that internationally. But at the same time, a lot of those people are my age, and they're getting old and retiring, and we've had lost a couple of the senior fistula surgeons in the last year or two, and there's not a real strong evidence of a great younger middle-aged group that's going to step in and take over. There are some, but this is the big gap I would see in fistula staffing in the future, that we've seen kind of a developmental arrest where a lot of people have been through formal training programs like FIGO, and they get certified as a basic level fistula surgeon, and then 10 years later you talk to them and they're still basic level. Why aren't they moving up? There's a lot of reasons. We talk about that in the manual. And then if the numbers are trending down, the other thing that I can tell you, but I can't go into because it would take too long to explain, is that more and more of the cases are complicated, which is unfortunate because we need more of these expert levels, and the experts are reducing in number. So how are we going to oh, okay. Erin, can I ask you to do that? Because I don't want to.
Oh, sure.
Yeah.
Why don't you finish your sentence?
So how do we do staffing in this new era of fistula? So let me pause 1 minute for Erin to make an announcement.
Okay. Thank you very much, Steve. It's very enlightening and interesting so far, and we just want to pause for a moment to recognize and thank UNFPA's Executive Director, Dr. Natalia Kanem, for joining us. We're very pleased that she's online. Thank you. And we'd like to invite Dr. Kanem to say a word. Thank you. Over to you.
Thank you so much. I'm sure it's difficult here because I'm in Geneva for the World Health Assembly. And as you can tell, there's a lot of excitement behind me. Can you hear me okay for now?
Yes. Yes.
I just wanted to, first of all, thank you for organizing the seminar. It's really important. Fistula is actually the signal that our health system failed. And the hope that we could do something about it with surgery is really, for me, part of the holy grail for the inequities that women who suffer. So I would like to thank Dr. Aros for shedding light on the subject, and also to our team around the world to say that this is something that we really use as a marker for 2030. So more power to those really involved at the grassroots level. So thank you. I didn't want to take too much time. I just wanted to cheer you on.
Thank you.
Okay, go. See you.
Bye. Bye. Thank you so much, Dr. Natalia, for your leadership, UNFPA's leadership, especially towards the new UN vision of ending fistula by 2030. Thank you for joining.
All right, we're making great progress. Just a few more minutes here, and then we'll open it up to questions. The other big thing about on the clinical side is that all of a sudden we've gone from the data desert to a move towards evidence-based care. And landmark event was this randomized prospective multi-center trial in catheter management that was done a few years ago, WHO and in gender health. And what was really encouraging was that it was followed very soon, in a record short period of time, by a set of WHO guidelines based on the results of the study. And this, to me, all of us who were involved in that study, we wanted it to demonstrate that it was possible to generate good evidence that was practical and that could make things more efficient, less costly, safer, and more effective. And so that's here. And I think that the contagion around evidence is spreading, and we're seeing more and more good papers from younger fistula doctors, and that's encouraging as well. Now, in nursing, the one thing that I would say is nursing in 2006 for version 1 was really wild, and I always point to, if you look back, it's got the recipe for the beeswax that you put on vaginal packs after surgery from Addis Ababa. I can tell you the beeswax days are gone. You know, nursing is catching up too, and that's very encouraging to see. And we're moving towards standardization and modernization. And one of the big tools is included in the book, and this is called a clinical pathway. And this is just a very short snapshot, but this is, if you're a nurse on post-op day 1, you're the night shift nurse, these are the lists of your tasks, and you tick them off as you go. And this is only part of them, you know, but none of this is high tech. This is like, look at the patient, check the urine, blah, 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 blah. But it standardizes everything. It helps more junior people to know that they're covering everything. And I think tools like this can be very effective and very impactful in institutional-based care. So we have a very good nursing chapter with a link to be able to download these pathways to use at your facilities there. Same thing in physio. Physio has gone from being kind of an outlier to being a part of whole person care, and it's very important in the treatment of incontinence, which is a whole other topic after repair. And the physio chapter is really well done by 2 really highly academic physiotherapists, so I'm excited about that and looking forward to your feedback. Same thing with rehab and reintegration. Yusuf, the guy's picture, his wife Habiba, is really academically minded and publishing tools and assessments and impact things, and even talking about the ethics involved in rehab. I mean, can we ethically ignore the need for rehab services while we say maybe not everybody actually needs them, and how do we balance that? They're bringing in evidence-based to rehabilitation, which I think is important because it's expensive and our resources are limited. And they're beginning to track outcomes to let us know which of their bright ideas are actually effective, which we all need to do. The last thing that I'll say is that we need to pay attention to long-term outcomes. This is talked about in the manual, and this is another place where we have almost no information. And some of the early anecdotal information is scary. Some of the people doing outreach in Kenya have bumped into old patients who were discharged doing well and dry and found that 40% of them are now wet 2 or 3 years later. We need to look into that, figure out why and what we can do about it, or we can't say that we're actually taking care of the problem. So standardization is needed in how we report, and there's progress coming on that. That's addressed in the manual as well. Just talked about reintegration. There's changes in funding, huge shifts happening. You know, as you all probably know, the US's biggest funding goes to Fistula Care Plus, and that's past its current 5-year cycle and winding down. It'll wind down soon. We don't know when exactly, but I can tell you that no one knows yet what's going to come after that, and it's probably going to be very, very different and not like before. So we can't count on the Fistula Care Plus project doing its thing. The UN depends on funding just like everybody else does, and it seems like it's just as worried internationally about where funds are going to come from, and none of us are immune to that. And we have to think about how to program in an area where we're not as sure about what's coming in. I can tell you that some of the other private NGOs that have been prominent are scaling back. One just put a 10% across the board cut into place, and so everybody's feeling the pinch. Finally, as a former missionary, I think it's frightening to see how few mission organizations now say that they can afford to do healthcare, and mission hospitals, which have been a real backbone, especially in Africa, are beginning to close down. So the remaining challenges, got to keep at it on epidemiology. Once you hear about these new tools, we need to use them. We need to have better approaches to help women who have been deemed incurable. That's a whole topic that I could talk an hour about. We need to look at other morbidities. For instance, infertility is one that's never gotten much press, but affects a large number of women with fistula. And I've had so many women, I say, oh, I hear you're dry, how come you're not happy? And they'd say, when am I going to be pregnant again? So, and then how to program in this new world where the numbers may be decreasing and the funding may be more of a challenge, and how to retool the good work that we've done into a different form that's going to be effective with these future challenges. So I'm going to stop there. That's 44.
Well done with the timing. 1 minute to stay. Thank you so much, Steve, for walking us through these many highlights, holistic kind of picture of what's changed in fistula over the last 25 years plus, and what's changed from our original version 1 of the global UN guidance on fistula to this current version that's forthcoming now, version 2. So we wanted to leave plenty of time for questions, so thank you for keeping to time. We now have 45 minutes, and we've got a number of colleagues on the line around the world. We've got some colleagues in the room as well, and I'd like to hand over to Bridget now to kindly facilitate the question and answers and discussion.
That was good, because I was going to say, no matter what the topic was or anything, if you have any question, Bridget is ready to answer it.
So thank you very much, Steve, just to echo Erin, and then thank you, Erin. So colleagues, could you kindly mute your microphones for a little while? We are glad that you are very excited to ask questions. Okay, so we have okay. So we have this session for questions and answers, and for your questions, and we're ready here to help you answer them. And we'll be glad if you want to ask a question, kindly just unmute yourself, and then we'll listen to you. So colleagues on the field, if you have any questions to ask.
Is there anything in the chat box?
There's currently none in my chat box for now.
But maybe they want to talk.
Hi, Agnes.
She's muted.
She's muted.
Agnes, could you kindly? Okay, she's muted. Is there anyone online who would want to ask a question?
Yes, I'm Vavita.
Hello, Avita. Yes, we
Hi.
can hear you.
Can you introduce yourselves, please?
Yes. Good morning. I'm Vavita Leblanc. I'm maternal health specialist at UNFPA country office in Haiti. And
Thanks for joining. Bonjour.
thank you. And I really wanted to thank you all for this opportunity for us to intervene and also to listen about what is going on the fistula planet. Thank you very much, Steve, for these informations. I'm just wanted just a quick intervention and how from Haiti perspective we feel like we still have the burden that a lot of countries have faced and maybe get over it. We are, as other countries, dealing with iatrogenic fistulas, and this is this is evidence that have been raised by the Obstetric and Gynecologic Society, which is one of our implementing partners in the fistula program. But we still are in facing a lot of obstetric fistula as well. So I feel like we have a sort of figures that are very particular to Haiti, because the maternal mortality is still very high, but we are in the same time dealing with a raising of iatrogenic fistula cases as well. So it's a very complex situation that we are living here in Haiti, and I don't know if there are other countries that have the same complex situation as Haiti, but I feel like the other countries, they've been through fistula issue through two phases. The first phase is the phase that Steve was talking about obstetric fistula, and then now iatrogenic fistula. So I don't know what are your insights about that, and maybe what kind of recommendations that on what we should focus on to move on with our fistula program. Thank you.
Thank you, Vavita. Is there any other question? Otherwise, then we'll just ask.
Hi, I do have a question.
Okay. Hi, Agnes. Could you kindly introduce yourself?
Yes, hi. I'm Agnes. I am the Program Associate for Maternal Health and the Fistula Focal Points in the UNFPA Sierra Leone Country Office.
Hi.
Great. Thank you for joining.
Thank you.
Howdy, buddy.
Fine. How are you, sir?
I'm fine.
So my question is mostly on the iatrogenic fistula, because I think UNFPA's work focuses mostly on the obstetric aspect. Even the International Day of coming up that we're about to commemorate is International Day to end obstetric fistula and not iatrogenic fistula. So I'm just wondering, going forward, is UNFPA going to incorporate programming to target iatrogenic fistula? Because like the demographics by the two types of fistula are completely different. To develop an iatrogenic fistula, first of all, you have to be able to afford a pelvic surgery or C-section in most cases, or normally such fistulas are more prevalent in Western and developed countries, and obstetric fistulas are more prevalent in developing countries. So I'm just wondering if UNFPA is going to add on iatrogenic fistula, or if it already is a part of our programming that I'm not aware of. How is that going to work out? Given that we have the funding is declining, and now we have these other types of fistulas to think about as well.
Thank you, Agnes. So I'll just ask Steve if you answer that for Haiti.
Thank you, because if we waited any longer, I wouldn't be able to remember what the Haiti question was. So, so let me start with the Haiti question. So this is a perfect example of what I was trying to get across, that the picture is so different in different geographic locations, even to the point of what kind of injuries the women have. I can remember my first time in Ghana. I was expecting to see all 14-year-olds, and they were all 30-year-olds, you know, with obstetric fistula. They all got it on their fourth pregnancy, not their first, blah, blah, blah. So everything is different. And there are still places in the world that have an issue with obstetric fistula, and some of the, DRC with all of the conflict in the East, and Nigeria is going to have a fistula problem for a long time. They're making progress, but it's still a significant issue. And so I don't want to imply that the obstetric part has gone away. And so the first thing that I would encourage you in Haiti is to not be ashamed that you still have an obstetric fistula issue that you're dealing with, and to go great guns at that. And fortunately for you, I think people in other countries have been able to try out a lot of different ideas, and you can benefit from their experience as you do programming to try to eliminate obstetric fistula and to deal with the women that have it. Of course, you're all aware that basically there's no difference whatsoever in the measures that we use to reduce maternal mortality and to reduce obstetric fistula, because both of them are all about access to emergency obstetric care. And so anything that you do for one is going to benefit the other. So I'm a urologist. I'm not an obstetrician. I can't talk as an expert, but I would just say that number one, Haiti still has an obstetric fistula problem. Fine, let's face it and let's deal with it. And the fact that Bangladesh doesn't, that's fine for them too. They're going to have a national program that looks different. But I think that the beauty of UNFPA in a way is that you seem to be very nationalized in your approaches. There isn't a world approach per se to things. And so I think that gives you the freedom to program as you see fit to deal with that. I would say, though, that whether you have an obstetric fistula problem or not, that the iatrogenic thing is an overlay on that everywhere. And that is just, it seems like the world has discovered that you can make money doing surgery. And so there's all sorts of non-qualified people trying to do it. I would also say, that having just been a long time, I'm not picking on Bangladesh, it's just that I was just there for a month, but as a result of their push to reduce maternal mortality, they really tried to improve access to cesarean section. So now on the private side, they have maternity hospitals that don't have a delivery room because they do 100% C-sections. And one of their most common indications, the doctor told me, for a vaginal delivery, vaginal delivery, it was, doctor couldn't make it in time to do the C-section. So those kind of, every cesarean has a small risk of iatrogenic fistula. But if cesarean sections are exploding, that's an area that needs to be addressed to deal with iatrogenic fistula. Then there's another lady I spoke with this year, had an iatrogenic fistula after a hysterectomy. She showed up at the appointed time after having no ultrasound, not any exam or anything to determine that she really did need a hysterectomy. Then her doctor was busy, so her hysterectomy was done by the clinic administrator, who was not busy at the time, and she ended up with a fistula. So those are things that need to be regulated through justice systems and not professional society. I think if you're an administrator that feels free to operate on people, you need to go to jail, so there again, I think UNFPA and the UN is in a unique position because you have an entree with government that a lot of other NGOs do not. And you can go in and speak to ministers of health and ministers of justice and to the president of the OBGYN Society for that, and say, what are you doing about safe surgery in your country? And there is a lot of talk about safe surgery measures that you can tap into in Haiti or elsewhere in the new version of the manual, and use of checklists and things like that. So it is a very complicated picture, I agree with you, but I just wanted to underscore that the fact that you still have an obstetric problem, I know now, I wouldn't have said this 10 years ago, but I know that you can make an impact on that and you can make it go away. And so you have to be, fistula has always been a both and thing. We have to do both prevention and treatment. We have to do both social programming and clinical programming. And now we have to do both iatrogenic and obstetric programming. And so maybe we're well qualified to do that since we've already been in that mindset.
Thank you, sir. So we go on to Agnes' question, which relates to how UNFPA plans to focus, or is UNFPA is focusing on iatrogenic fistula already, or if we're not, how do we plan to do that? So I'll just hand over to Erin. So.
Sure. Thank you, Agnes, for your question. And that's a very good question that I think is probably in the minds of many other colleagues. And I would say yes, we are already working on not only ending obstetric fistula, but also ending iatrogenic fistula. There's quite a lot of work being done, even if we don't always talk about it in the language of iatrogenic fistula. But our holistic integrated program on maternal and newborn health that many of you online will be familiar with, our maternal and newborn health thematic fund program, is addressing iatrogenic fistula on many levels because we're promoting safe access, universal access to skilled care at childbirth. So for example, through midwifery care, through, for those women and girls who need it, who experience complications during pregnancy and childbirth, through emergency obstetric and newborn care, even our portfolio on maternal and perinatal death surveillance and response is looking at cases in which something went wrong and what went wrong and how could that have been prevented, whether that was a maternal death or perinatal death or a severe morbidity or injury. We are also, I'm sure many of you have heard about the quality of care initiative that Bridget, Jean-Pierre, myself, and others are involved in, which is joint with WHO and UNICEF and a number of partners. So promoting high quality care for all women and girls. So again, it's not, half the battle is to help women and girls get to a health facility. But then once they get there, they need to receive timely care, high quality care, safe surgery if they need it. So there's really a lot of cross-cutting work being done on quality of care. So all of that work contributes to preventing iatrogenic fistula. And in terms of treatment, I think Steve talked about, and you'll be familiar with our holistic approach on fistula and the 3 pillars of prevention, treatment, and social reintegration, not to mention advocacy as well. So in terms of treatment of iatrogenic fistula, all of the surgeons I know, and Steve, you know, I think many of them, I know a lot of them as well, I've never heard a surgeon say, oh, sorry, this is iatrogenic fistula, I can't help you, please go away. All of the surgeons that I know of who are capable of treating that fistula will treat the fistula in the woman and won't discriminate based on whether it's obstetric fistula or iatrogenic fistula. And I would say the same in terms of social reintegration. So the programs that are out there to support women who are recovering from fistula, or those unfortunate women who are not yet recovered, they may have been deemed inoperable or incurable. I think the programs don't discriminate against whether they had iatrogenic fistula or obstetric fistula. The needs may be different, and the programs do try to tailor them to the individual needs of the women and girls. But I think basically all of those aspects, prevention, treatment, and social reintegration, are being addressed. Of course, there's more work to be done. We don't want to see any case of obstetric fistula or iatrogenic fistula. And I would just mention as well, Steve touched on the aspect of justice. As you know, the theme for this year's International Day to End Obstetric Fistula is that fistula is a human rights violation. So together with our colleagues in UNFPA and other organizations, we are doing and continue to do advocacy, whether that's through UN resolutions, through legislative processes in countries, to promote ending fistula as a human rights issue. And also all of our advocacy around the Sustainable Development Goals, and particularly at country level, as well as global, that countries are really advocating for the fact that if we're serious about ending poverty, promoting gender equality, universal health coverage, universal education, ending inequalities, all of that means we have to end fistula as well. So I'll leave it there, and if anyone else would
Yes,
like to
we
comment on
we have two questions from Animesh. Hi, Animesh, if you're online, would you like to go ahead with your question, or we'll read what you have written?
Hi, Animesh, thanks for joining.
Okay, so I'll just go on. So Animesh is a technical officer working with UNFPA Bangladesh, and the Bangladesh recently launched a second national strategy to end fistula before 2030. He wants to know. Hi, Animesh.
That's her son.
And children.
That's why she can't talk.
Oh, he can talk. Yes. All right, we understand. So for Animesh's first question, he wants to know how we can grow interest for in Bangladesh. The current rate of surgery in Bangladesh will take another 20 years to complete the backlog of obstetric fistula. So his question is, how can we grow interest for the surgeons to do fistula surgery? And of course, when we're talking about fistula surgery, not just the surgery, but the quality of the surgery. And then his second question is, do you have any example of tracking rehabilitation or reintegration in other countries? So these are two questions from Animesh.
Yeah.
How we can grow the interest of surgeons to do quality surgery.
So this issue of the backlog is another vexing problem. I always have a picture in my mind that if you go way out into the jungle somewhere, there's this clearing and it's all filled with women who are waiting for fistula surgery. And if we could only find where that is and take a bus there and get, it's not like that. Estimates of the backlog in Bangladesh have been revised downward, but it's really hard. It's an ethereal thing. It's not women who have already shown up and want care but have to wait for it. It's an estimate of how many women haven't accessed care yet. And so that's hard to know how to quantify and know how to deal with. But I can talk about how to get more surgeon involvement. And one of the a couple of things. There seems to be a prevalent, let me save that one. There's a prevalent perception out there that fistula is a professional dead end. If I am a young Liberian OBGYN, spending 10 years in fistula does not do anything to advance me up to senior consultant status or to give me more job security, because there's no certification that's either nationally or internationally recognized. People talk a lot about the FIGO training curriculum, and when you finish that, you get a certificate and it says, I have finished the FIGO training curriculum. It doesn't say, I'm hereby certified by the International Federation of Obstetric and Gynecology as a fistula surgeon. It says, I finished the course. So it's a desperate need. And I think in Bangladesh, the level of involvement of the International Society for Obstetric and Gynecology, they seem very interested in fistula. And maybe they would be open to somehow having this certified as a subspecialty underneath gynecology. Other people have kind of thrown up their hands and said, well, the only way that we're going to be able to get certified would be to maybe start something called urogynecology training in my country. And that's a fellowship that gynecologists do after they finish all their other training to learn some more urology. Which is a segue to say that in a lot of countries, especially in Bangladesh, I would say, the urologists are quietly doing most of the difficult cases, and that's an untapped resource. And they need recognition, and they need to be networked, and there needs to be a community belt that includes both gynecology, urology, and in some cases, some of the biggest named surgeons out there are actually started out in general surgery as well. So that's not only gynecology. but this idea that you have to have some kind of piece of paper that you can take to the ministry that says, I need to go up 2 levels on my pay scale because I'm now a certified fistula surgeon. There's no pathway like that anywhere that I know of in the world. And that's probably one of the biggest needs to unleash a lot more potential. As far as the, I cannot specifically remember about papers that are talking about outcomes in reintegration. There is a terrific general bibliography that the reintegration people gave us, who said, just for extra reading, you might consider this. And I think if you peruse those articles, that could be a source for you to find evidence of that type. So that's in the forthcoming manual, yeah. So that's a cop-out, but that's the best I can do.
Okay. All right. Thank you, Steve. We have Esther on the line. Esther wants to ask a question.
Hi, Esther.
Hi, Esther.
I'm in the Niger office. I'm working on the Spotlight Initiative. And actually, we have integrated fistula in the Spotlight Initiative in Niger because it is such a big issue, and we are working on the link between gender-based violence and harmful practices and sexual and reproductive health. So it seems very appropriate. While we were discussing the groups that are most at risk of violence, we're looking at multiple factors, and fistula came up, but so did other complications such as vaginal prolapses and uterine prolapses and other surgeries that are linked and yet probably do need a different set of skills still. But the question was, is there a thought internationally to be moving towards maybe taking into consideration other surgical needs as well? You know, considering certain countries with very high fertility might have actually more problems linked to these than to fistulas. So I was just wondering if that is a question that's been asked in other countries as well, or if that is specific to Niger.
Very helpful.
Nagode Sosei. Yeah, the reason I'm being silent is because this is the question we all hate to try to answer. And yes, people have talked about this internationally for a long, long time, especially now in the context of reducing numbers in some areas of obstetric fistula. Should we use our capacity on other maternal morbidities like prolapse? And I don't know that I've ever seen a hard figure, but it's at least 10, well, maybe 100 times. It's much, much more prevalent. There's no doubt about that. And so that, I guess as someone who spent their life in fistula, I would say, well, somebody ought to help them too. Somebody ought to go do that. But leave my money alone. Yeah, I want to keep working on fistula here. And this is this whole balance thing that I talked about. We're in a real ethical dilemma to know that women are suffering. They don't care if they're suffering from a uterus that drags on the ground when they walk down the street versus leaking urine. You know, they're just suffering. And all of us want to help all of them with all of that. And there is overlap. Probably most people who know how to do a fistula repair could also do a prolapse repair. So I think that this is an open topic still. Currently, the head of Fistula Care Plus, Lori Ramonzi, is a urogynecologist who has really been outspoken about incorporating prolapse services into Fistula Care Plus's programming. And I can tell you that it hasn't been very successful, that they've had that as a goal and haven't been able to do it very well. It's still, this is a thing that's early on rather than 20 years of experience of how do we integrate the needs for other things. So I hear you, I agree for you too much, as they say in Nigeria, but I don't have a great answer for you at this time, and that's more of an Aaron question than a Steve question. So.
I don't know if anyone else wants to jump in.
Go ahead.
Yeah, thank you, Esther. And it's really great to hear that you've integrated obstetric fistula into the Spotlight Initiative. We are hoping that more countries will kind of follow your trend and tap into the spotlight resources to include fistula and potentially other morbidities as well. Yeah, you raised such an important issue about prolapse and other maternal morbidities that women and girls do suffer from. From the perspective of UNFPA country offices, and if any colleagues are on the line from those offices who would like to chime in, please feel free to do so. But I know that at least a few country offices, and I'm thinking of, for example, Nepal, I'm thinking of Ethiopia, as well as Bangladesh. I know we have, or had Animesh on the line, who do see quite a heavy burden of prolapse as well as fistula. And some of those countries have begun to program for prolapse in various ways. So, you know, we could put you in touch with colleagues and so you could find out a bit more about their strategies and where the resources are coming from and kind of lessons learned there. And yeah, as Steve said, I think it is a challenge for us and a dilemma because on the one hand, we have member states last year at the UN General Assembly in December 2018, adopted a new resolution on fistula, which really upped the bar for us. It really gave us a much more ambitious vision on fistula, ending fistula by 2030. You know, it was ending fistula within a generation. Now the world is saying, no, 2030, which is great. In many ways, it's an opportunity. At the same time, it's quite a challenge because with the resources we have currently, we're not going to make it. So we need to, you know, significantly mobilize more resources, more support to meet that goal for ending fistula by 2030. At the same time, yes, we don't want to neglect other women who are suffering and girls who are suffering from other morbidities. So it is quite a challenge, and I think we are hoping we can use that resolution and the new vision from the member states as a tool to really advocate for more support, more action, you know, accelerated efforts on ending fistula.
Can I just add on to this great discussion? Hi, I'm Soyol. I work in technical division as a coordinator on youth and demographic dividend, and kind of like, you know, seeing, as you said, where we sit as UNFPA, we're seeing all of the intersections of how, you know, different interventions in the clinical, non-clinical, and community sphere should come together, especially that, you know, the patients of the fistula tend to be those young girls that, you know, do need those, you know, attention, opportunities, and resources. But coming back to the question and the discussion that we just, you know, had through the question by Esther, I think it's also hopefully the same member states that have proposed this you know, commitment, they will also remember it when the universal health coverage discussion will happen in September, where, you know, the question of whether including sexual reproductive health and rights of women and girls should be part of the universal package or not should not be a question, because, you know, that's the only way that we can indeed end fistula within the by 2030. And yet we find ourselves how much we have to fight for, you know, availability of the preventive measures, of the family planning, of the information, you know. So it's and it's great that, you know, at least from UNFPA, how we want to integrate those issues together so that the community is aware that, you know, this is not just one issue that drags you to the hospital, but it's actually the community effort. And then coming back to the question of dwindling resources, I was quite inspired by some of the stories of those survivors, and even your story in a memory of one of the survivors who passed away, how there is so much potential in community raising voice and actually making demand that, you know, the governments, the, you know, other players start actually, you know, providing more comprehensive approach to this. But thank you so much for the presentation and the discussion, because I think there's a lot of ethical and other challenges in this whole kind of a discussion, and that's what makes it even more challenging, but also exciting for us as a UN.
Thank you so much.
Thank you, Soyo. So we have Furaha from Tanzania.
Hello.
Asante sana, Furaha. Thank you for joining.
Oh, asante sana.
Karibu.
My name is Furaha Mafuru. I'm a program analyst maternal health and family planning, but I'm also a fistula focal point in the Tanzania country office. Thank you very much for a wonderful presentation. I've learned a lot from the question and answer. But my question is on changing the epidemiology. Here in Tanzania, we do not have exact figure on the prevalence, on the incidence. It's a big challenge for us, but we are estimating clients. And I'm aware that survey has been conducted. So eager to hear from you. When should we expect to hear about the dissemination of this? Thank you.
Thank you, Furaha. Thank you. Okay, let me ask Agnes, you had another question. We add on Agnes' question and then we address it.
Yes, I did. Can I just say I didn't quite get the question that came before mine, the previous question. So please, when answering, just repeat it so we can catch it. But my own question was, this year we're celebrating 25 years of ICPD, and one of the is leaving no one behind, right? As UNFPA. So I'm just wondering, for fistula patients with incurable or inoperable fistulas, how are we not going to leave them behind? Does UNFPA have any programs in place for women that do not benefit from our fistula treatment programs?
Thank you, Agnes. So for Tanzania, Furaha wanted to mention that in Tanzania, they do not have data on incidence and prevalences, but she's aware that there is some work going on to get some new global estimates and country estimates on incidence and prevalence. So she wants to know when this information or this data would come out. I'll hand over, I'll ask Erin to address this.
Okay. Hi, Furaha, thank you for your question. So I think some of you on the line may have been at our maternal newborn health thematic fund planning meeting last September in Nairobi. And at that time, we had our partner from Johns Hopkins University, Professor Saifuddin Ahmed, who presented preliminary data on prevalence of obstetric fistula in our 50 plus countries that UNFPA and the Campaign to End Fistula support. So those were preliminary estimates that were presented, which do include Tanzania, and I think probably most of the countries on the line. So since that time, Professor Ahmed and some of his team have gone back and been refining the statistical model. They also, those of you who were there remember, we had quite a long interactive dialogue with Saifuddin, and different countries had inputs and wanted to, interact with Saifuddin and say, oh, we've got some data in my country, or I want to discuss some issues with you. So that has been taking place these past few months. We have a draft manuscript, so the data will be published. We were hoping it would be published in time for the International Day, but it's taking a little bit longer. We have a draft manuscript that's now undergoing review internally with UNFPA. So my hope would be in the next couple of months that would be coming out. And as we've done so far with, I think, many different countries, we can share the preliminary data that we have from Johns Hopkins along with the presentation. I know, Furaha, with you and your team in Tanzania, we kind of walked through that presentation that was given in Nairobi. So if countries are looking for their individual country estimates, we can share that, even knowing they're preliminary and will be finalized soon, hopefully in the coming couple of months.
Thanks.
Thank you, Furaha.
Thank you. Steve, would you like to take on the question from Agnes?
No. So, yeah, this is a huge thing since 2006. We had a big meeting at Harvard about women deemed incurable. We don't even know what to call them. Incurable puts stigma on stigmatized women, you know, and then the argument is, well, incurable in my place might not be incurable for somebody who's done it for 30 years or whatever. And so this is another very complicated issue, but let me just say a couple of things. First of all, not leaving the women behind is the key concept here. And I really liked what you said about women who don't benefit from treatment. You have to understand that surgeons are like George Bush. Said he was a fixer. Surgeons are fixers. If you go to a surgeon with some problem, they're going to do something to you to try to fix it. Well, many times in fistula, if they have a particular set of injuries all at the same time, we know from the outset that they can never be fixed with surgery, that they're going to remain incontinent. And so one of the first things that you can encourage the professional community in your countries to do is to have criteria and to stick with them, because what we don't want to see is women. I've seen women with 15 attempts at solving their fistula problem and still they're wet. That should have stopped after one or two. So learning which ones don't benefit from treatment and have them labeled that way. What that means then is they need help from us in other ways. And it's not always clear, I can tell you, which particular women really need social reintegration and rehabilitation services. For instance, iatrogenic women tend to have their fistula for a much shorter period of time. And they probably have better resources because they're probably more independent financially. So that's a for instance, in Niger, we had an agricultural group that developed a hybrid tomato plant that bore fruit in the dry season when everybody else has come out in the rainy season. And they gave the seedlings specifically to fistula patients so that they would have an edge in the market so they could sell tomatoes when no one else had tomatoes. I know of a place in Kenya with a strong reintegration program, and they had an incurable patient ask her what she wanted to do, and they trained her to be an automobile mechanic because that was what she wanted to do, and she knew she could support herself. We have given so many women sewing machines when maybe there was no market for selling sewn goods where they lived or whatever. So we need to be a lot more realistic and focused that our interventions are really going to help this woman to survive. And I would say that for any reintegration program, the ones at the front of the line need to be the ones deemed incurable or the ones that we know that won't benefit from further surgery.
I have a couple of questions. Do we still have more online?
Yeah, I think.
Yes, we have Claudia. Claudia wants to.
Hello.
Yes.
Hello.
Thanks for joining.
I'm Aster from Ethiopia.
Oh, hi.
Hi, Esther.
Hi.
Hello.
Thanks for joining. Go ahead, please. We've just got a few minutes left, but we're listening. Please go ahead, Esther.
Hello. Good morning.
Good morning, Esther.
And sorry, I'm joining lately, and I do have one question. We have a plan to monitor the obstetric fistula, elimination of obstetric fistula strategic plan. We are doing good in prevention, in the treatment, but we are lagging behind in monitoring. So we do have a plan to do surveillance because it's not included in the ATMIS. So my question is there any country who is including obstetric fistula into the surveillance to share us their experience? Because we have a plan, we developed TOR. So if you have any experience on this area, I need guidance. Thank you.
Thank you, Esther.
You want to ask Claudia?
Yes. So
Thank you.
we now move to Claudia. Claudia, can you ask your question and make your contribution, as you said?
She needs to unmute herself.
Claudia.
Hi everyone, it's nice to be here and thank you for organizing this. Hi, can you hear me?
Yes, hi Claudia.
Hi, Claudia, thanks for joining. We're listening.
Hi, thank you for organizing this. It's nice to see you all, especially Dr. Eros. Hi.
Great.
Okay, it's a bit of feedback, so I'm not sure you can hear me clearly.
We can. It's good. Yes, go ahead.
Okay, so I wanted to thank you for the opportunity and for being able to hear from other colleagues what's going on out there. My question pertains to fistula survivors. So we want to use them as, hello?
Yeah.
Yes, we hear you.
Oh, we are having
to use them as advocates here in Ghana, and we are trying. Maybe I should type the question because I think you can hear me very well. I'll type it. Okay, let me type it. Let me type the question.
Sure.
I'm going to stop the video. Might help with the bandwidth.
All right.
Oh, yeah.
So we have. We have access. It's Mukas. Peter. It's Peter.
Yes,
Peter,
yes. Bridget, can you hear me?
Yes, we can hear you.
Hi, Peter. Thanks for joining. We've got about 1 minute left, so can you make it quick, please? Thanks.
Yes, I am on the move. I'm actually going for the Fistula Day commemoration in one of the districts up country.
Oh, great. We'd love to hear about it afterwards in the coming days.
Yes, but my question goes to Steve. In terms of what we always say, routine repairs. Routine. I'm wondering whether in the revision of this guideline, we have tried to put what by exactly routine repairs. Because I think it is not quite clear. And then two, are we going to share that guideline with all the country officers?
Okay. All right. Thank you, Peter. Thank you very much. So we quickly move to Esther's question, and she wants to find out if there are any countries with experience with regards to monitoring and of their fistula program surveillance, and they need that aspect in Ethiopia. So if there are any examples. Before Erin and Steve come on, I'd also like to encourage all country officers, if you have such experiences, kindly let us know so that we could also be able to share with countries. Yeah. So
once again, I'm not expert, but I would say I know that in Bangladesh, it is included on data that's routinely collected, and I would say that Bangladesh is probably the most advanced country in terms of its data collection system. And so perhaps approaching them to ask their experience would be a good place to start. I know I've been there a couple of times in the past 2 years, and they said that it was officially a reportable thing, but nobody at the ministry had any of the numbers or knew. And so it seemed like it was not being done practically on a day-to-day basis, but they had made a policy that they were going to do that. But anyway, you could interface with the staff in Bangladesh. The other thing about monitoring fistula, especially is if you're in the phase of trying to get to eradication, is we talk about making fistula a reportable case with ministries of health, just like if they got smallpox or something like that. and there's been terrific back and forth about the ethical issues of making fistula reportable. Because once again, the argument on the no side is that this stigmatizes an already stigmatized person, that if their name goes to the ministry as having some horrible condition, that that's bad. So there's not universal agreement about that, but I think if we are eradicating fistula and not just treating it, we're going to reach a point where the last few cases in individual areas need to be reportable so that we can find out what individual part of the system failed and do something on a case-by-case basis to deal with that. I know we're out of time.
All right, yes, thank you. And the last one.
Thank you.
From Peter about that. Esther, could you please mute your mic?
Okay,
the last one about Peter about routine repairs.
Okay, I can tell you on the basis of the big clinical trial that we did, we limited the catheter management study to simple cases. We went through 2 years of effort to try to come up with a definition of what a simple case was. Collaboratively at surgeon meetings, we drew drawings and said, would you call this one simple? And everybody raise your hand. We made a terrific effort and we finally gave up because we couldn't get anyone to agree. One issue is that what you see at screening, when you're in a tent somewhere and it's very hot and there's no light, and you look in and you say, aha, I think this one is an easy one or a routine one. You get in surgery and find out once the patient is anesthetized and the light is good and the position's good, that this is not an easy one, this is a horrible one. Or the other way around can be true too, that you screen under bad conditions and find something that appears to be difficult and it turns out to be simple. So we need to improve that and standardize at what point are we actually classifying them. So I would say at least not in a remote setting. The remote setting should be, is there a fistula or not? But then the surgeon should be screening them and putting some kind of a qualifier as to difficulty. But because we cannot tell well beforehand if it's really bad or not, that makes a certain strategy fall apart. And that is to say, well, we have a number of surgeons who can do the simple ones. We'll let them do that. And then we'll have the difficult ones referred into the capital to have that done. Well, many times people are fooled. And so you can end up with surgeons who are only capable of simple repairs in a situation where they have a difficult problem. And then if they give it a try, that lessens the ultimate chance that that woman has to be dry. So I am in favor of having maybe a leaner workforce that's more capable and to focus on going back to surgeons that we've trained and to get them comfortable with the more difficult cases, since we cannot classify them into routine or not ahead of time. And so, so Peter, I want to encourage you that there is no definition. It doesn't appear that there's going to be, and so therefore, no, we're not sharing it because we don't have one.
I wonder if you meant routine versus camps, but
you
can always follow up online afterwards by email if you still have further questions.
Do you want me to talk about that for just 1
So
second?
that was my understanding. Peter,
Okay.
did you mean routine versus camps or campaigns? If you're still on the line, Peter?
He said about routine repairs, it was not clear which ones are routine.
Okay,
Yeah,
we can follow up afterwards.
yeah,
maybe.
I think so.
Just to answer the other part of Peter's question, yes, the new guidelines, once they're finalized, and they're currently going through internal clearances here in HQ. So once they're finalized and, you know, ready to go, they will be shared with all countries. And did you want to make your note?
Yeah, maybe we just stay tuned to the maternal and newborn health community. That's where you'll find all the updates on fistula as well. So I'm glad to hear some enthusiasm about it. Just follow the maternal and newborn health community, and we'll keep you up to date there as well.
Yeah, and thanks to those of you who've posted on it, like Faraha and maybe others, and it's your community as well. Do feel free to post on there.
Yeah,
Veronique is a good coach about how to post if you need some help. And
yes.
just want to
So
say,
Yes, that's the last point. So we will be glad to hear about all that you did or you're going to doing and what you're going to do for the International Day to End Obstetric Fistula. Please share your stories and your documentaries. We'd like to have them and also share your experiences with other countries. That's very important. And we'd like to all know what we are doing.
There are already great input on the community actually on the subject, so feel free to add to it.
Yes. Profile your work, shine the spotlight on what you're doing in countries. So just to thank everyone again so much for joining. I know for some of you it's really late, probably past your bedtime. And we're delighted that you joined and really appreciate your thoughtful, important questions. And thanks to Veronique, our technology whiz, the webinar has been recorded. So even those who weren't able to join will benefit from all of the questions you asked. And of course, Steve, it's an honor to have you, and we really appreciate all the work you've done on fistula, all of the women and girls you've helped over the years, and for helping to guide and improve our UNFPA and Campaign to End Fistula programming. So on behalf of everyone here in UNFPA and the campaign, thank you very much.
Happy Fistula Day to everybody.
Bye.
Bye. Thank you.
Bye.
Bye.